on X-ray, there is more chances of CPAP failure. And CPAP failure has an association with bronchopulmonary dysplasia, with death, IVH, NEC, everything. So it's not something good to happen. So what currently we are doing in CPAP failure is we are giving surfactant. And this is being supported by the 5 recent guidelines which have been published since 2019 to 23. The UK guidelines, the European guidelines, and our current NNF-CPG guidelines, they recommend that you give surfactant when you need a CDP of 6 centimeter or more of water, and if the FiO2 is more than 30%. This is based on the fact that if your initial FiO2 is more than 30%, you are more likely to have CPAP failure and worse outcome. The Canadian guideline still sticks to 50% based on the various trials, and they say that if the FiO2 is more than 50%, then you give surfactant. The recent guidelines published by Bhandari et al., which is the RDX next guideline from USA, uses a cutoff of more than 30% in first 2 hours of life and more than 40% beyond 2 hours of life, and it has mentioned certain criteria in which you need to give surfactant. The European guidelines have also taken into account the lung ultrasound score. Although I'm a great fan of lung ultrasound, I'm still to really look into this particular clinical practice, how it is going to impact our surfactant therapy. So what do we have from these few slides? That 1/3 to half of extremely low birth weight babies may fail on CPAP, which is again associated with worst outcomes. Gestation and oxygen requirements are important predictors. Current guidelines suggest to give surfactant mostly if the FiO2 is more than 30% and if the CDP is more than 6 centimeters of water. Well, we all know how does surfactant act, and we have been taught about the labeless law since last many years. And in this law, the pressure is proportional directly to the surface tension. What happens during expiration, because of increased surface tension in the air-liquid interface, there is a tendency to collapse. Without surfactant, the surface tension is close to 50 times per centimeter. If you give surfactant, the surface tension decreases to 5 to 30 times per centimeter depending on what type of surfactant you have given, what dose you have given. This surfactant helps to decrease the opening pressure of the lungs. It helps you to achieve higher volume, and it prevents the collapse of alveoli during expiration. But we are faced yet with few dilemmas. Which is the best surfactant to use? I have the commonly used surfactants, the Berectin and the Porrectin. Now, 2 recent meta-analyses have provided that Porrectin alpha in a dose of 200 mg per kg is better than Berectin in terms of improvement, in terms of decreased risk of mortality, decreased risk of death or BPD, and certain other outcomes. A few years back, I was getting confused with randomized controlled trials. Now I get confused with meta-analysis. 2 other meta-analysis, one is a network meta-analysis, and other is a systematic review of RCTs and real-world evidence. That means they have looked into database of various countries. They did not find any difference in death or mortality, depending on what is the type of surfactant you are using. So evidence is again maybe not very clear, not very robust, but the UK guidelines and the European guidelines and the NNF guidelines, they vote in favor of Porrectin alpha at a dose of 200 mg per kg. The Canadian and the US guidelines right now are silent on this particular aspect. So currently, as we understand, the choice is more in favor of Porrectin at an initial dose of 200 mg per kg. Now, what is the best time to give surfactant? And Dr. Dinesh Tomar specified that do not give prophylactic surfactant. Prophylactic surfactant means giving surfactant to all the newborn babies or preterm babies, which is not right because it increases the risk of mortality or bronchopulmonary dysplasia. And none of the guidelines are in favor of prophylactic surfactant. What we are currently doing is we're giving rescue surfactant, and if we do early rescue, that means we give surfactant to babies who fail on CPAP in the first 2 hours of life, there's decreased risk of mortality and chronic lung disease. But we may have situations where babies are coming to us after 2 hours, or we had a delayed surfactant because of any reason we were not able to decide. In those cases, late rescue should be done, and surfactant should be given to premature babies who fail on CPAP. There are various strategies now to give surfactant, and we are very well versed with something called Ensure since last 1992 when Werder first used this particular strategy. So in Ensure, you give intubate, you give surfactant, you extubate. The other strategy is to continue mechanical ventilation after giving surfactant. Now what has been found that Ensure strategy is better because it will decrease the need for mechanical ventilation, air leak and chronic lung disease. And probably a lower threshold, less than 45%, is a better strategy than a higher threshold. So Ensure strategy compared to continuing ventilation is an optimum choice if we compare these two. But the literature makes you more confused because there are other ways of giving surfactant. One strategy is in-rec-sure, where you intubate, recruit the lung and give surfactant. The recruitment can be by high frequency ventilator or could be by the means. Other very famous strategy is LISA or MIST, which is less invasive surfactant administration, in which you use a very thin catheter to deliver surfactant in babies who are breathing spontaneously on CPAP. Then there are strategies like giving surfactant by laryngeal mask airway, by pharyngeal instillation, and something which is truly non-invasive, which is nebulization. Now, what evidence do we have to give surfactant by recruiting the lung first and then doing it? The idea is that if the lungs are recruited, they are inflated, it will have better distribution of surfactant and it will be more effective. So the famous trial called the in-rec-sure trial, which compared recruiting the lungs by high frequency ventilator and then giving surfactant versus Ensure, was a multicentric trial conducted in Italy. And what it found, there was decrease in the rates of mechanical ventilation in the first 72 hours of life if the in-rec-sure strategy was applied. A Chinese trial was published last year in which the recruitment strategy was intubating and giving them a breath of PIP 25 centimeters of water for 15 seconds and then giving surfactant. And when they compared this strategy with Ensure, they found there was decrease in the risk of mechanical ventilation. But we are still scared about this intervention because if you look at the outcome, they have taken mechanical ventilation, not BPD or death. And we are still not sure about safety of high MAP in extremely low birth pressure or something like sustained inflation, which has shown increased mortality in the same trial. Then we come to LISA or MIST, which is known by various acronyms and fancy names. This is something which has generated a lot of interest in the last 2 decades. A LISA catheter is a very thin catheter, and it could be an angiocath, it could be a feeding tube, or it could be a special LISA cath or neofac, which can be used to give surfactant in babies breathing spontaneously on CPAP. Now the evidence is quite robust, and mainly the trials from Germany and now trials from India have shown there is decreased risk of mechanical ventilation and bronchopulmonary dysplasia. However, just a word of caution, the largest trial called the Optimist trial published in 2021 did not show any difference in death or primary or bronchopulmonary dysplasia. So there were higher trends of death in the MIST group, but the BPT was lesser in the MIST group compared to the sham treatment group. So the evidence is robust with LISA, but there are problems in terms of pre-medication. We may require more than one attempt. There could be surfactant reflux, dislocation, coughing, bradycardia, and so on. Now, this is a small video, and this is a small clip from the movie Matrix, and it is something when Keanu Reeves is taught how to learn the different skills by Morpheus. He is distracted by a beautiful girl in the red dress. This is what should not happen to us. We should not be distracted by LISA alone. You have to understand that LISA is a complete package. You have to deliver LISA along with all the golden hours packages. You can't just do LISA and forget about hypothermia, sepsis, and other aspects. And we need to gain experience ourselves before we actually practice LISA. Other methods of giving surfactant like LMA, we published our small experience on giving surfactant by LMA. It doesn't require intubation, could be done by healthcare workers. And there is some evidence in favor of LMA because there are 6 RCTs which show decreased FiO2 requirement, decreased intubation, decreased mechanical ventilation with giving surfactant by LMA. But this you can do only in babies who are more than 1 kilo, 1.2 kilo. A truly way of giving surfactant in a non-invasive ways by nebulization, and there's almost 9 studies which have shown these beneficial benefits of this strategy, and it decreases the risk of intubation in the first 72 hours. But there are issues with particle size. Surfactant could be lost in the airways, and there are issues with distribution of surfactant. I'll take 2 minutes, Chairperson, if it's okay. Thank you. Now I have again confused you. I have discussed Ensure, I discussed nebulization, I discussed laryngeal mask, I discussed LISA. And this is what is said in a book called Harry Potter by Severus Snape. Well, it might have escaped your notice, but life isn't that fair. So all the myths are good. Which way to go, Dr. Anu? But I will solve a problem a little bit for you. This is a recent meta-analysis published, which has 16 RCTs and 20 observational studies, 13,234 infants, which compared all these strategies. And what they found that giving surfactant by a thin catheter compared to Ensure was better in terms of mortality, need for mechanical ventilation, bronchopulmonary dysplasia, PVL and NAC. In RCTs, at least giving surfactant by thin catheter lowered the rates of mechanical ventilation, but the other outcomes were not found to be significant. And Ensure compared to other techniques were similar. So what is cooking up now is surfactant plus steroid being given together, where surfactant is used as a vehicle. And the idea is that it will help the steroid to spread in the alveoli, which is called the Maragnoni effect. And there are 2 meta-analyses published which show it is beneficial in terms of decreased risk of bronchopulmonary dysplasia, mortality, and other outcomes. And a large trial, because this trial is from China, we just stop telling, I'm finishing the slide. The last trial published from China showed all these benefits, and currently 1,038 babies are being recruited in Australia, in New Zealand, Canada, and Singapore in the PLUS trial to find out whether it's beneficial. So this is what is going to come in the next few years maybe. So CPAP is a beneficial strategy, and I discussed about the various kind of strategies to give surfactant. I've already crossed my time limit. So we are still actually searching for the holy grail in neonatology, and we are still searching for the right interventions to complete the best picture. Thank you so much, Chairperson.
Thank you, Dr. Anup. It was a very nice presentation of CPAP. I would like to say one thing. Although we have invented so many advanced things in neonatology since the last 10 years, but CPAP has been the backbone of neonatology since long. And mind it, in the emerging state like Jammu and Kashmir, where we are lagging behind for the tertiary care NICU support, CPAP can change the whole scenario in all the SNCUs. We have been doing in Punjab, and we have seen, even if you don't have that machine with the indigenous CPAP also, the rate of ventilation has dramatically decreased, and from the SNCUs, the referral to the NICUs for the tertiary care has been dramatically decreased. I would suggest the J&K teams to train their trainees and DCH candidates for the indigenous CPAPs wherever the other CPAP machines are not available. And the most important fact which they have highlighted, that their babies get detrimental during the transportation. And if we transport the babies even on indigenous CPAP, we can increase the prognosis by so many times. Any questions from the audience?
Okay, yeah, Dr. Kaushal, yes.